So we're going to get started here. I would like to welcome everybody to Genetics for Microtia live chat with Dr. Pedro Sanchez and Dr. Cheryl Lewin. Dr. Sanchez is the Director of Genetics at Cedars-Sinai Medical Center. And Dr. Lewin, would you like to take it away and give a formal introduction?
Sure. Absolutely. We're very happy and excited to have Dr. Sanchez with us today. Our relationship actually goes way back, probably over 15 years ago, when I was a fellow at Children's Hospital Los Angeles and Dr. Sanchez was there. We worked together on a craniofacial team, which some of you may know about, but it's like all the different disciplines that surround children with craniofacial issues, be it clefts or in some cases microtia or syndromic children like Treacher Collins. So we've had, many patients we've shared together, and he is a phenomenally brilliant guy. Geneticists are the smartest doctors ever. So I always pick his brain for stuff that comes up and I can't figure out an answer to. So we actually had Dr. Sanchez speak at one of our early LA MAC conferences at Terranea back in 2014. And he's gonna sort of give us an updated lecture from what we learned from him back then, and hopefully it'll be useful to those of you who are wondering the genetic component to your child's condition or your own condition. So thank you so much, Dr. Sanchez. Take it away.
Thank you so much. It's a great honor to come back and give you guys a little bit of an update on the slides, and some of the questions you guys have are fantastic. And so I'll give you a little bit of background on the slides I'll present and just highlight a couple things about the presentation. There's a lot to go through. I will make it a short talk, so we'll have some questions at the end. At the bottom right of my slides, they're numbered. So if you have a specific question, just write down that number and you could email me or text me, or you could say, can you go back to slide number? And that'll help us sort of stay organized. I'll walk you through what I know about some of the differences about ear development, and hopefully it'll help you understand Microtia and OSHA. All right, so I'll give you a little bit of background on myself. I trained as an undergraduate in medical school at UCLA. I went to Philadelphia for 5 years at the Children's Hospital of Philadelphia, and was here at Cedars for a year of fellowship before going to CHLA, and now I'm back at Cedars-Sinai. And let me so as a pediatrician, I'm like a general pediatrician, but focus on conditions that have structural birth defects or something with a genetic underlying cause. I try to help families understand whether or not there's an underlying genetic influence. And the goal is really, if you know why some birth defects happen, maybe we could give you targeted information, help you provide more targeted therapies, and find your own community, a new family of friends, basically, sort of like the group that you have here. And ultimately, you want your kids to grow up and live a healthier life. So some of the things I do is just pattern recognition. And I always love seeing families and getting to know them. And, genetics sometimes is very technical. I like to sort of start from scratch and walk you through some of the approaches without really having people speak up. People really ask, tell me a little bit more about this condition. And people say, well, what do they have and what do they need? And without really disclosing their diagnosis, these families have a loving family. They have a worried family. And yes, if you look at the pattern, they do have have Treacher Collins syndrome. And what do they really need? These people need to have fun. They need to meet others, and they need a team of doctors that understand their diagnosis. And so that's the goal of trying to have these types of talks is, not only getting a diagnosis or understanding the biology of a structural birth defect, but what can you do to stay healthy, and how do you meet others out there with the same type of condition? Those pictures were from a website called Positive Exposure. It's the founder is one of my friends. His name is Rick Godati, and I've met him at many of the genetic conferences, actually different family conferences. They're not actually medical conferences, but he goes and he's a professional photographer, and he used to take pictures of supermodels, and then he really got found a passion to help take pictures of families, and ultimately he's trying to redefine how we look at different conditions out there. A lot of the pictures that are online or in books are very dry and unfriendly. And, you know, he has devised this website that has medical education about different conditions, including Treacher Collins and some of the ones that you might recognize. And there are families describing the condition in their own words. So this goes to the medical professionals, the students that are trying to learn about the condition, and maybe it might be a good place for families to start off with instead of going to other medical specific websites. He has this key phrase saying, you know, change how you see how you change. And I think it's a great way to present some of the genetic conditions, although my pictures aren't as great as his. Yes, the pictures that I showed you earlier are of a condition called Treacher Collins syndrome. Some people use a technical term called mandibulofacial dysostosis. And there are certain characteristics that you would try to look for if you were a medical provider. The genetics of Treacher Collins syndrome is mainly caused by TCOF1, but there are other genes out there. And so I think understanding some of the biology helps us think, why are there little differences amongst the families that you meet? And maybe if you do have Treacher Collins syndrome, it'd be good to know some of the patterns that we see in individuals, because that might explain why your child is a little bit different from the rest of the group out there. For example, there's a condition with a smaller head and features of Treacher Collins syndrome, and their development is much different than the other kids. So the goals of the talk is really to try to answer some of your questions, overview some of the factors influencing ear development, not just focus on genetics, but obviously as a geneticist, I am biased. And I'm not going to focus really on individual questions if you have something specific about your exact report, but I'd love to hear from you guys about what questions you do have. The ear is a very complex structure, and there's a lot of things that influence the development of an ear. We look at different structures and the anatomy of it to try to understand the biology. Maybe if you have a difference in the lobe, has different factors that influence either you have a bigger lobe or attached lobe or no lobe at all. And in front of the ear has different genetic drivers. Microtia has different causes, both genetic and environmental influences. We'll go over many of them. Most individuals have microtia on one side, mainly on the right side, and most of you will have microtia that's just isolated. So the literature says 40 to 80% are isolated, just an ear difference, but you could look at those numbers differently, saying about 20 to 60% have more than just an ear malformation. Definitely everybody has a different level of understanding genetics, and whenever we see a patient or a family, we start from the beginning. What is a cell? What is a chromosome? What is DNA? What is a gene? And how do genes influence protein? So we try to keep it as simple as possible and walk you through this over several visits. So I do like the idea of getting to know families, and I don't necessarily have young kids learning about the genetics, but once they're old enough and have their own questions, I sort of walk them through some of the things we've done. Making an ear is, again, such a complex structure, and the embryology of just making a person is one of the miracles of life. And so if you look at some of the research that studies the biology of how cells get to the right place of the anatomy, I know some researchers that actually put little dye in an embryo of a mouse or a chick, and they watch the cells move on a camera to see which cells go where and what part of the anatomy is influenced. So they basically take little videos and follow these cells and say, this gene might influence this part of the ear. And looking at the embryology and those structures, little clefts and prominences during the early formation of an embryo, you could see the different structures of the ear that might develop as an adult. And so the different clefts and different pouches and arches have different genetic drivers. That's as much embryology as I'm going to go to, but it's really beautiful videos that I'd love to get into. Some of you might worry about the pregnancy or some medications or exposures during the pregnancy. And really, it's a complicated process. I think if you found out that you were pregnant and during the first week you went to a wedding and had a lot of alcohol, and you were worried whether or not that influenced the concept of or risk of a birth defect, actually, the early part of development, the first 2 weeks, really isn't that critical. It really is the third week and on during the first trimester. So the ear really is at the bottom of the page, and it really is a continuous exposure to something that would be more worrisome on my part. But when you see a provider that's trying to help you understand whether or not there was an impact of either a medication or some kind of environmental factor, this is the critical window for embryologic development. How do we determine whether or not something's genetic or environmental? I think we have to either look at an individual and really dig down into your DNA, or for environmental factors, we really have to step back and look at populations and big numbers. Microtia is not so common, so it really takes participation from families like yourselves and collaborations with different centers. We're talking about other projects that are trying to get the numbers so that they can really separate out groups and learn a little bit from them. So ideally, the early studies looked at twins. And if you know about twins, there's identical twins that share the environment and share their DNA. And there are fraternal twins where they share the environment, they're in the same pregnancy, but they share half their DNA. So if identical twins and fraternal twins had the same amount of microtia, if it was equal, then maybe there would be a more suspicion that there was an environmental cause. Here, in actual, these are numbers for microtia, that identical twins have higher rate where they both have microtia. They call that concordance. They both have microtia in about almost 40% if they're identical. In fraternal twins, about almost 5% of the time, both of the twins have either unilateral or bilateral microtia. So I'm trying to point this out, that saying that there's a higher likelihood that genes play a bigger role in microtia than environment, but yet some people haven't had the right tests yet, or the science hasn't caught up to learning about the embryology or the anatomy of ear development. Some of the epidemiology studies or some of the studies done by the government show different rates of microtia and anotia. So if you look at the prevalence of anotia or microtia, like back in 1996, this is a study from China, people who were living in a rural environment, it was more common in a rural environment in 1996 versus in 2007, where it was more of an urban environment. And you could also look at Eastern versus Western China, and they concluded recently that it's more found in the Western part of China and more in the urban cities. So whenever you look at different literature or different papers about, well, what is the cause of microtia? It's sort of an evolving story, and it depends on when the study was even done. So you look at studies from the 90s, you might have a different conclusion than more recent studies. But it's always nice to get your questions and hear your comments about, what are your ideas? There have been early publications back in the 80s about altitude and how in Quito, Ecuador, there was a 5 times higher chance of having microtia than in other Southern American countries. If that was the case, there'd be other high altitude countries with a high prevalence of microtia. And that's not necessarily the case. Tibet is a higher city than Quito. And there are, places even here in California where there are cities that they don't see a higher rate of microtia. But maybe in Quito, there is, certain ancestries or different nutrition that is playing a role in the cause of their ear difference. Some people have thought maybe there's a vascular disruption. And this is a really important one to focus on because, if you have a small artery or an artery that's missing, that's critical for an ear to develop, maybe one ear would be smaller than the other. And so this has been described in other birth defects, and maybe that's that plays a role in some of you, but there's some evidence for and some evidence against. So the support for, it's asymmetric. Sometimes it's usually on one side versus the other. And there are some animal studies where if you block the artery, sometimes the ear is also smaller in these types of studies. But evidence against, there are some genetic conditions where people can have asymmetric ear differences. And the vascular hypothesis doesn't explain when both ears are affected. And it also doesn't explain people who have other things aside from microtia. So I would call it like microtia plus. There are some medications out there that do cause vasoconstriction or the artery to spasm. And they've been studying those medications and that they do cause certain birth defects, but so far it isn't really linked to microtia. So maybe further research needs to happen. Maybe groups like yours have to ask each other, hey, maybe were you on any medications and what medications were you on, so that we could all learn. I know that we were talking earlier with Dr. Lewin, and she really has to study the vascular anatomy on every case, because you can't just read a book and say, oh, every artery goes in this pattern. Each individual is different, and even left versus right can be different. So when you hear about the cause of microtia and OSHA and look at the epidemiology, there's some really great studies. They're very dry information, no pictures, very complicated results. And at the end of the day, their conclusions say, things are associated or maybe a risk factor, but it doesn't mean it causes it. So this next section, it's a moving target based on the numbers of people who are studied. People have seen a link with low birth weight, or maybe it's more common in boys, or their first pregnancy, or large families. Definitely twins have a link with multiple different birth defects, and so microtia is one of them. Older parents, different ethnicities, and then education level may be linked to other things like nutrition. And then there are certain fetal environmental causes. Some things like alcohol or medications or diabetes can be associated. And some things you really can't change, like whether or not you got an illness or where you live, either an urban area or rural. Air pollution was in one paper. You can't really change that. But one thing that we look at when we're trying to understand a birth defect is a concept of something called a teratogen. And basically it's either a chemical or a medication or something in the environment that influences the baby. And so people look at alcohol or infection or smoking to see if there's a link with a certain birth defect. If you have questions about your own family or your own pregnancy, I think you have to sort of reflect a little bit and know that the baby's here now, that the baby's doing great, and that you're in a whole different situation, but as a parent, it's hard not to wonder. So some things that I like to to ask the families is, how much was the medication, or what was the dose, or what was the timing? And everybody has a different susceptibility. And sometimes there's interactions between other things that are linked. So if you smoke, maybe you also drink a lot of caffeine, or if you drink alcohol, maybe you do other things beside alcohol. So it's a complicated process, but that's what we do to try to understand um, the exposures. These are the types of categories for environmental factors that people look at for birth defects, either infection or something physical, or a drug or a chemical, or a maternal disease like diabetes. But the reality is, if you were on a medication or you worked in a certain environment, there are standards to say that there's enough proof or enough evidence to put that out there to the literature or to the community. Say we should be careful with this this medication or this exposure. It has to be rare. It has to fit in the right time. There are some subtle physical exam findings that we do in our clinic. And if there's a pattern that we see amongst a couple individuals, then that might support the idea that this might be a teratogen. Then we could expose different animals in a laboratory. But if it doesn't make biologic sense, then it has to make sense, basically. If this exposure, if people were worried that it causes this brain difference, but the medication doesn't cross the brain barrier, then maybe it's unlikely to cause that problem. There are certain medications that are definitely linked to microtia. There's a medication that is used in organ transplant or immune suppression. And in the first studies, all the cases had microtia. And in fact, it's a spectrum of exposure now. And now people know if you're on this medication, you should be careful getting pregnant. There are other epidemiology studies looking at nutrition and vitamin supplementation. And even though the papers are really complex, this group is very, very careful about what they put out there because they don't want to worry people. In this one paper, they said, well, lower intake of carbohydrates might influence the risk or association of microtia. And then higher diet quality may be protective. It wasn't necessarily statistically linked or strongly linked, but they saw a trend. I'm sure during your pregnancies, everybody's prescribed prenatal vitamins. Most of them or all of them should have folic acid. But aside from folic acid, when my wife was pregnant, we were looking up all the different prenatal vitamins, and there were over 50 different types that we could have ordered online or got for prescription. So there are some standards, but some things you really can't say, see a pattern amongst the group. Other factors that people have looked at are maternal obesity or pre-pregnancy diabetes. And there are numbers in the middle of the screen. The numbers like the risk of, or the association of obesity and microtia is lower than the risk of getting microtia with diabetes. There were some protective effects, like if you took preconception folic acid, that might have protected a little bit of having microtia. And if you were African American, you have a lower rate of microtia atresia. But I think looking at obesity and diabetes was a key factor for this study. There are other things that we see when we meet families that have a structural birth defect. And sometimes it's not just an isolated ear difference, but they have other things like a heart issue or kidney issue or other problems that affect the nerve. But there's plenty of other people who have diabetes during the pregnancy and have children that have no problems at all. So we're not necessarily sure if it's the sugar that's causing the birth defects or the other factors out there. There are people who perfectly control and manage their diet, and they still have the birth defect. And so I think it might be some genetic factor and some environmental factors that are playing a role. We definitely bring up diabetes a lot just because, at least here in the US, it's becoming a major epidemic. Back in the 90s, it was very uncommon to have obesity and diabetes, and now it's affecting almost 10% of the US population. A lot of people have diabetes, but just haven't met the criteria to meet, to get formally diagnosed. They'll say, oh, you're pre-diabetic, but not necessarily say that you need a medication. And then I'm going to switch topics a little bit just to jump to some of the genetic evidence of Microtia atresia and why we even think about doing some genetic testing for families, even though most of the time the Microtia is isolated. So we do see some families that have a pattern where it might have been passed from a parent to a child, or maybe the grandparent has an ear difference, and it could be pretty subtle, maybe just a little bit smaller and not completely absent. When we do genetic testing, some families we do find a chromosome difference or a gene change. And there's other things that we're looking at to say, well, maybe we should focus on genes sometimes. Like there's mice, when we put a mutation in a gene and knock it out, you could see that it's a lot smaller in this one mouse model. And then to give you a little bit of background about genetics, it's very, very complicated. I don't want to oversimplify things, but it's good to just hear, you know, where we've gone just in the past 10, 15 years. So we all have 46 chromosomes. We didn't know we even had 46 until 1956. So before 1956, we actually thought we had a different number. So we've been looking at our microscopes and trying to learn more about biology since then. And back in 2001, we had the first draft of the human genome. So all the letters and all the genes, we actually figured out where they were. And so we have 3 billion DNA letters. Only 1% of them actually code for protein. So those are genes, or that's called an exome or exon. So we know we have 23,000 genes. And if we sequence all 23,000, we can find the cause of about 85% of genetic disorders. So the goal would be trying to figure out basically that one person, trying to identify that one person in California, for example, trying to look through all the letters or meet all the people in California and pinpoint that one genetic cause or find that one person. So to sequence all those genes, back in 2001, it cost $100 million and took 10 years, but technology has rapidly changing. And in fact, earlier this year, they announced that you could sequence a whole genome for about $100 and it takes about 3 days in the laboratory. What they're not telling you is that to sequence, to use this technology, you have to buy a $10 million machine. And then once you have the machine, you have to put a lot of samples on there. And on average, it costs about $100 per sample just for the chemistry. So there's a lot of room to grow and learn, but the idea is eventually it'll be just routine. In my clinic, we do very complicated genetic testing, and we are getting better success in getting insurance to cover the costs. But this is how we approach what we call a gene-first approach, where we sequence the DNA and try to find the one genetic change. And so we go from 3.5 million genetic changes and sift through the data using computers and algorithms. Ideally, we find that one genetic cause, but sometimes we have maybe 3 or 4 things to talk about. And we need to do a thorough exam to see which condition it might be. So if this genetic change causes problems with hands and feet, and on exam, the child's hands and feet are normal, then maybe that gene is not likely to be the cause. So in my clinic, we really try to integrate an exam, a history, and all the databases and research that we could do to try to find an answer. Sometimes we walk in the room and we see a certain pattern or a certain structure that reminds us of a different patient, and then we could just go directly and do that one genetic change. I know Dr. Lewin's experience can easily recognize many of these conditions, and so she might not even call me for a diagnosis because she's seen 30 other patients with the same condition. So one of the questions people ask is, should you even do genetic testing? There are definitely some benefits, but some risks that people will say, well, you know what, not now. Or I'm curious, but my partner, my wife, or husband isn't interested in hearing about that. They're really worried. They are focusing really on the current treatment. They want to know about surgery versus their next pregnancy. So I think everybody has to take it individually and then sort of find a team that'll help them walk through those questions. I sometimes see families and I say, you know what, I think this is not the best time, and we'll see them back later just because they're dealing with a lot of other things. The chances to do genetic testing are very vast. Some people say, oh, I had it done before getting pregnant, and this is definitely not genetic. I have to always take every family individually, and usually we have to start from scratch, tell them a little bit about how complicated things can get. And it's really an alphabet soup, and the number of tests we could do is a lot broader than just you had a genetic test and it's not genetic. Sometimes we do a blood test or a saliva test, or actually take a little tissue during the ear reconstruction, because sometimes there's a genetic change just affecting one side of the face and not the rest of the cells where you're getting DNA from the blood. So I don't want to complicate your story, but the idea is that it's nice to have a team that is thinking beyond just you had a test and it's negative. It's also important to have someone walk you through the types of results. It's not just, is it you have a genetic change or you don't. There are sometimes you have a genetic change and it's not really clear, and we have to go and wait for a new publication to either upgrade or downgrade the information. So I don't necessarily look at things as good or bad. I personally look at it as good, good, and good. I'm happy for families that find an answer. I'm happy for families that don't have any changes. I really want to walk them through their experience and give them everything they can. That if they have questions, we're always there for them. I do a lot of research for facial birth defects, and so we just got a paper accepted for this project that does facial recognition of different conditions. And we used to go to a lot of different family conferences, and then one day we'll have the ERICLES conference again, and maybe we'll get to meet you and show you some of these projects that we're working on. But the idea is, can you take a picture of someone, and can a computer separate out each diagnosis separately? Because some things are so subtle that I don't have a term for this little subtle prominence on your cheek or underneath your lip. So in these pictures, these are different conditions, and blue is meaning that it goes in. If you take an average face, it'll be depressed or recessed, and red means that it goes out a little bit more prominent than the average face. And in fact, we could separate out each of the components and start making a virtual diagnosis just with a picture. Some of the research is pretty fun to look at. This is an average of about 3,000 3D pictures of all the different genetic syndromes. And I think each of these individuals with a genetic syndrome is just part of that spectrum of normal. If it was a very common syndrome, then that would become the normal. So this is just an average of a bunch of pictures going back and forth of all the different syndromes. And you could say, well, wait a second, that looks a little bit like my cousin. And I think it's just a neat part of the studies that we're doing. Sometimes people hesitate about approaching a diagnosis or trying to get genetic testing done. And I think it's a personal question. Sometimes the mom doesn't want to know and the dad wants to know, or the opposite. But if you have questions about, whether or not something might have happened during the pregnancy, and it's clearly something genetic, it's sometimes a big relief for parents to hear that it had nothing to do with that one medication or that one fever that they had. And so I think it's important to normalize a lot of this stuff. But if you do feel guilty, I think that's also a normal response that some people have. So that's the main focus of my talk. I did want to leave some time for question and answer. And I hope you learned something today.
Well, awesome. Thank you very much for that. That was very informative. People have chimed in with tons of great questions. Dr. Lewin, did you have anything you wanted to expand upon before we get into the questions? I know the maternal parental guilt is one thing that you usually hit on at all the conferences. Is there anything that you want to just add to that point?
I just underscoring what Pedro was saying, it seems like such a fundamental parental emotion. All of us that are parents just feel in any situation something's not perfect with your child, you tend to feel guilty. I see it almost universally amongst my parents that I talk to, especially when their babies are born and this is a brand new diagnosis and nobody expected it and nobody really knows anything. There's just this overwhelming tendency to look inward and think that you must have done something wrong. And I feel like you can't hear it enough times from professionals like Pedro and myself, who we live in this world, and we just want you to understand you got to get rid of that guilt. You just need to leave it at the door. It's unproductive in every sense of that word. And really, it's much more productive when you can just say, you know what? We love our kid. We did nothing wrong. We're just going to move forward. So really, that's just my big point, is to please try hard to just throw off the guilt that everybody so commonly feels around this.
Great. All right, we're just gonna jump right into some of these questions. This question is from Matthew. Our son has 2 of these conditions, cleft palate and bilateral microtia. Could this be passed down to his child as Treacher Collins, even though he doesn't have that condition?
Well, it's interesting the last comment about Treacher Collins, because at one time people thought Treacher Collins was just one gene, and if you sequenced that one gene and it was normal, they said, oh, you don't have Treacher Collins. I like to step back a little bit with specific diagnoses in saying people need a thorough examination. Sometimes it's something very subtle that you could see that would raise your suspicion and say, well, I've seen many people and I really think you do have Treacher Collins syndrome. Even if the test was negative, it's important to look at that pattern and say, I'm really suspicious or not, and then do the test. Because now we know that there's multiple genes out there. And I think maybe in the next couple of years, they'll find 1 or 2 more genes out there. So even if you have a negative test, does not mean it's not genetic. It just means they didn't find it. There's one thing that I mentioned that I sort of overlooked about genetic testing. When we sequence all the genes, yes, we sequence all 22,000 genes, but we only know the function of half of them. So half the genes, we don't even know what they do. So it goes in the research and discovery area. And so some people have had all their genes sequenced and had a normal report, but yet a year later or 2, we find out that there was an important change in that data. And so we have to relook at it.
for that, I do see a number of kids that have cleft palates, sometimes submucous cleft palates, and bilateral microtia in my clinic. In fact, I always check palates on all these kids because we often find abnormalities with either the nerves or the muscles or whatnot with the soft palate. But so for that patient, is there, they're trying to figure out, you know, what you're suggesting maybe that child may have Treacher-Collins, but it's not diagnosed yet. Is that what you're saying? And so we may, but a subtler form.
So I use Treacher-Collins just because it's something that's very well known in the community.
Okay.
But I only say, I use it just as we suspect something genetic. So if you look at just cleft palate alone, half the kids with just isolated cleft palate have something genetic. The other half, we still don't know. Now, cleft palate and microtia, then we start going down the realm of, well, was the palate there because the jaw is small? Or was the palate there, the palate was abnormal because of something else? So if the jaw is very small, and Dr. Lewin looks at that palate of whether or not it's a V-shaped palate or a U-shaped palate, that gives us some idea of what was going on during the pregnancy.
So it could be when this young child is older, there will be further genetic studies that they could do to help that parent answer the question of the likelihood that that could be passed down.
Exactly. I think I love following families, and some of the information in a couple of years will be outdated. And what I say is, I give you the best information that I can today. But the tools right now are incredible. So I sequence people's, all their genes a couple times a week, just because insurances are covering it and people are really finding value in that. But on the opposite side, if the baby's doing well otherwise, like we mentioned a little bit about diabetes and things like that, most of those kids that I know have great development. And so I really try to integrate that kid's story into whether or not we decide to push for testing.
Makes sense.
Great. A couple other questions relate to bilateral microtia. Is there anything, specific that you could address regarding bilateral microtia? There are a few different questions. Have you been able to identify the gene that causes bilateral microtia, and how will CRISPR be able to help correct those genes in our children so it isn't passed down?
I like both of those questions. And what we do every day is just try to work with the family to say how far we should go into helping them do tests. Because it's complicated, it's a balance between what we need to do right now versus what we should do in a phased fashion. A newborn baby isn't walking and talking. We don't know how they're doing otherwise. And so we got to give them a little bit of time to get everything optimized, their nutrition, their hearing, everything, before we even say how they're doing in their development. So I think bilateral microtia, it raises a little bit of a red flag for me to say, hey, I'm over here if you want to see me. But it doesn't raise a red flag to say, this is something definitely genetic. I just say, unilateral, I wonder, but things can be genetic and still be asymmetric. So I think there are several dozen causes of ear differences. So I don't just put the whole topic into one bin saying, we know everything about that one organ. As far as CRISPR, I love that topic just because I was telling Dr. Lewin that I'm now giving talks on gene therapy and gene editing, and there's an important concept to separate out. There's editing of individuals after they're born, and there's editing of individuals before they're born. And right now, one is more encouraged and the other one is in the future, we're going to just imagine that in 20, 30 years after we understand the safety and things. But I know of a couple conditions that have gene therapy in trials. So in particular, right now, the best thing you should do is just think about what are we trying to fix and why. So obviously the ear is a complicated structure. There are outer and inner ear structures that are important. And I think Dr. Lewin does a great job in the outer part. And then there's the implants and things that people are working on for the inner and the middle. But it's a great question because I'll go back to understanding the cause. There's different causes, different genetic drivers for different conditions. And maybe there's a gene therapy for this one cause, but not this one. So finding your family's story is really important. And then asking the question, whether or not there's some benefit is the answer.
Okay. Have you seen a link to those that have the MTHFR mutation?
Yeah. So the MTHFR mutation affects folate metabolism. And so some people look at that and say, is it important for structural birth defects? We know that folate metabolism is very important for biology. And there's some link to things like cleft lip and palate. And so I haven't seen it, but yet there are some studies that look at, if you're on folic acid before pregnancy, do you have a lower rate of microtia? And some studies say, yeah, just a little, it is a lower rate. So can your genetics, the way you metabolize things, impact that? Maybe. So it's sort of coming together. But right now, there's not enough people in those studies to say, we're really convinced we should test everybody for, or, it's not a helpful test. The real issue about the MTHFR mutation is it's so common. It's so common that I think if you have the mutation, you should be aware of it, but you also should think about preconception folic acid. And I think that's what anybody who's fertility age, I think 15 and above should be on some kind of women's vitamin.
There was a question too about could the microtia be caused by like pregnancy safe antibiotics? I believe that was that question. Any chance that could be a cause?
I haven't heard of that, but I think there's a lot of studies on antibiotics because a lot of women need it. And I think there's some risks of having infections that might overweigh some of the things that people are worried about. So if you did have an infection that needed antibiotics, urinary tract infection or any other type, I think everybody's trying to weigh that. And because it's such a common drug prescribed, the whole range of antibiotics, I think some of the databases should be flagging that when in countries that have nationalized health and they would see that this drug is a danger during the pregnancy.
Okay. And then another question, any chance like a mom that was completely stressed out the first month of pregnancy that could cause the microtia?
I like that question because a lot of people ask that. I mean, we're getting people from all over the country, the whole world. And, there are financial stresses, there's nutritional stresses, and then there's war-torn countries where people have to leave and be refugees. And I think it's a terrible situation, and it's terrible to compound that with a child with a birth defect. Right now, there's not really a strong push to say there's a high risk. The babies are really the evolution of making a person is driven to protect the baby. So moms that have really bad nutrition, the goal is to keep the baby and keep the baby safe. the question is, out of the 10,000 people that have malnutrition, can some of them have a problem? Maybe, but it's not the majority.
Okay. A couple of people have addressed having a cousin with microtia. Is there genetic testing that should be done?
Yeah, I like that question, because what I do is I don't just see one patient. I do family-based studies. I draw a family tree, and I like people to bring in their family pictures. People used to have these, albums of families, and online, I'm on a lot of Facebook groups of different conditions, and one of them said, look at my grandpa and look at his brother. And the question is, they might have something new that's just in their family, or we might find something that's common that is just a subtle difference that wasn't recognized. So I like that question. And when I do approach a family, sometimes some labs charge me one price to test not only the child, but both parents, plus that one distant relative. And then they sequence all the genes and see what's inherited and what's not. Because if the baby has a genetic change and that uncle has that same genetic change, then we would put more focus on that genetic change. We would, versus, they don't share anything, then maybe it might be two isolated issues.
Mary had a question about slide 18. The mother with lupus is suspected as one cause of microtia. If so, could you talk on that more?
I apologize for putting that in this. It was really just a general, it wasn't specifically for lupus, actually, for microtia. It was on just a general, what we call teratology talk on other types of medical issues.
Okay. And is there, there's someone who's asking for like a good website besides lewinair.com, of course, that would help talk about like microtia related syndromes, possible causations, etc. like that. Maybe more the genetics behind the microtia.
Yeah, I think every time I pull a paper, they update the literature, but sometimes it's just not written for patients or families. It's very dry, and it's not helpful. Like, just to get a list, or you want to know, how many people have this, or I think it's a work in progress. I don't have a really good one thing to share with an individual.
Okay. Maybe like two more questions. Well, first of all, a lot of people are asking, they want to like listen to this again. Curious about some of the slides. This is recorded, and we will be putting a link on Dr. Lewin's live chat website. So stay tuned for that, but it will be on YouTube. And let me try and grab one more. Let's see. Is there a place we can submit our family scenario to a genetics research think tank to help identify causes?
Definitely.
Oh, microtia.
I think there are different approaches that you could take. One is to work with your team, and they would push you to the network that they like. And the other one is just to look online for different resources. I think we all have one genome, so you really just have to have it sequenced once. Whenever I do it clinically using insurance, I can actually ask for the lab to give us the data, and then the family can share it with whatever research group they like. Because the reality is there are databases that everybody sort of searches through to sift through such complicated data. And so the lab themselves, they'll look at the data free one more time. But after that, I like to put them into a group where they can actually study the genes again.
Okay, great. Well, I think our time is just about up. If we did not get to your question, I apologize. You can go ahead. It might be easiest just to send it to info@lewinmd.com, and we can forward that to Dr. Sanchez, or if you do have his email address from the slides, which is also on the recorded version, that you can contact him as well. But I hope everybody found this super awesome and informative like I did. There was a poll. Hopefully you answered just a couple of questions. I haven't done it before, so I'm not really sure if it worked. Let's just be honest. But Dr. Lewin, do you have anything else you'd like to add?
I just really want to thank Pedro for helping putting this talk together. And he is my go-to guy whenever I have, I'll have periodic patients that I'm talking to on Skype, and like something will trigger and I'll be like, oh, gotta ask Pedro about that, or gotta send a picture to Pedro. So, he's just a wonderful resource, and I'm very happy we got a chance to share some of his thoughts with everybody.
Great. Thank you for inviting me.
Always our pleasure.
Well, lots of wonderful, wonderful comments from people. So thank you for tuning in. We do have porous implant ear reconstruction wrists and just question and answer session coming up for live chat. So make sure you check out lewinear.com, conferences, 2020 conferences, live chat. That's how you get there. So I'm sure you remembered all that. But anyways, just stay tuned. Social media, website, whatever. Anyways, hope everybody's staying healthy, happy, and tune in again next time. So thank you, and stay tuned for the recorded session. It will probably be posted and updated tomorrow. Take care, everyone.
Thank you.
Thank you.
Bye.